Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers and specialists come together to learn about high-risk pregnancy conditions, share experiences and work together to ensure the best health outcomes for mothers and babies. Today we are learning about the identification, treatment and management of the high-risk pregnancy condition of epilepsy in pregnancy. But first, let's meet our expert trainers.
Hello everyone, I am Dr. Karishma Tharyani, a senior obstetrician and gynecologist practicing in New Delhi. In today's session, we shall be talking about epilepsy in pregnancy. Did you know that epilepsy is one of the most common neurological complications encountered in pregnancy? Up to 1 in 100 women may suffer from new onset seizures during pregnancy. Women who are known cases of epilepsy well controlled on anti-epileptic medications prior to pregnancy may even see a reduction in their seizure frequency during pregnancy. But as we all know, that these anti-epileptic medications may have an implication on the fetal health. So today, to help us understand the management of epilepsy in pregnancy, the implication of anti-epileptic drugs on the fetal health, and to understand the intrapartum and postpartum management of epileptic women, we have with us Dr. Poonam. Dr. Poonam is a senior consultant maternal and fetal health at CFMC New Delhi. Welcome, Dr. Poonam.
Thank you, Dr. Karishma.
Dr. Poonam, please tell us, how does epilepsy affect pregnancy?
So, epilepsy is a condition which affects the pregnancy in the way that a third of women may have the symptoms much more. So, the seizures which perhaps were not there before could come in pregnancy, and this is primarily because of the changes that happen during pregnancy, like the increase in the volume of the blood flow which dilutes the drug concentration. So therefore, the drug concentration which is usually there may need to be increased in about a third of a women should the seizures frequency be more. The other thing we need to remember is that anti-epileptic medications has some effect on the baby as well. 2 to 3 times more there are chances of congenital malformations which may happen, and therefore these women would need more scans as compared to the rest of the population. Also, we must remember that these conditions plus the medication that the patient is on can cause some growth restriction, which is to the tune of 3 to 4 times in these patients.
So basically, all epileptic women who are on anti-epileptic medications should be referred to a specialist or to a specialist neurologist so that the dose of the anti-epileptics can be revised.
So this has to be a constant process where the lady is dealt in a multidisciplinary setup. The inputs of a neurologist is needed, and time and again these doses of the drugs would have to be changed.
So Dr. Poonam, if an epileptic woman presents to an ANM, what is the ANM supposed to do, or how is the ANM supposed to manage such a patient?
So ideally, any women with epilepsy on the anti-epileptic medication should be counseled preconceptionally. But should the women come in pregnancy, the ANM should make sure that they see the women at the earliest possible, which should be before the 12 weeks. And the reason being, the folic acid has to be started, and this folic acid should be there throughout the pregnancy. The other thing which has to be incorporated into the notes is that mention of the epilepsy and the drugs that the patient is on should be on the maternal child health forms that is available. And along with doing the routine things like the detailed history and the examination, the more important thing is to understand what kind of epilepsy it is, what is the duration of this epilepsy, how severe the epilepsy is, and what is the type of epilepsy. So these are the history taking which the ANM should be concentrating on, and as soon as possible refer these women to the neurologist for further checkups and to understand whether the medication dosage is okay, and finally the further medical specialist who deals with the obstetrics and the fetal part of it as well.
So Dr. Poonam, you've just told us about how an ANM will manage a patient who has epilepsy in pregnancy. If such a woman presents to a medical officer, will the medical officer also do the same, or the management will differ?
So the medical officer takes a detailed history, understands what type of epilepsy it is, how severe it is, what is the frequency of seizures, if any, and the doses of the medication the patient is on. Certain medications are not good in pregnancy because of the effect it has on the fetal health, and therefore some medication like valproic acid needs to be stopped immediately and replaced with lamotrigine or levetiracetam, okay, and ensure that folic acid is taken by the patient. He then refers the patient back to the tertiary care centers where a neurologist has a look and rechanges the medication if need be. It is also important to understand that if a patient is without seizures for the last 10 years or has not been taking medication and has not had seizures for the last 5 years, after having a consultation with the neurologist, these patients can be referred back to the ANMs in the primary health care center for a routine low-risk women management as they are aware of.
So Dr. Poonam, just to sum up for our audience, the role of the primary healthcare worker in management of a woman with epilepsy is to ensure that a thorough history is taken pertaining to the type, duration, frequency and severity of seizures, to know whether the patient is already on anti-epileptic medications, if yes, to revise the dose. If not on anti-epileptic medications, the medical officer can start the patient on some basic anti-epileptic drugs which are safe for the fetus, and to ensure that folic acid supplementation is being taken by the patient, and to refer all these women on time to a specialist neurologist at a higher center. So Dr. Poonam, sometimes a situation may arise where a pregnant woman presents in emergency while throwing a seizure, or she throws a seizure in a primary health center during her antenatal visit. During such times, how should a primary healthcare worker manage such a patient?
In the time of emergency, the first thing that needs to be done is put the patient in the left lateral position. That gives good blood supply to the baby. Make sure that the airway is secured, and if there is any secretions that can be sucked. Oxygen, if available, can be put according to the the flows, like 5 to 6 liters a minute. In the meantime, IV access needs to be made, as well as to be able to take certain blood tests for basic examination or investigations. For example, the CBC, the blood group of the patient, and also the blood sugar. And then, if possible, catheterize the patient and then make arrangements for this patient to be transferred at the earliest possible to the nearest tertiary care center. Now, diazepam can be given in the dose of 5 to 10 milligrams with a slow IV or intramuscularly to help the patient in the convulsion phase. Once the patient goes to the medical officer can also give diazepam, again 5 milligrams, or lorazepam 4 milligrams, or even phenytoin in the required doses. The detailed history needs to be taken at some point to understand it is epilepsy, and if the patient has been on medicines, and if the medicines have been omitted for which the seizures have come, and then refer once again to the neurologist for further checkups and future management. So a couple of things here, Dr. Karishma. If the pregnancy is beyond 20 weeks, we should always remember preeclampsia and blood pressure and other parameters like pulse, respiratory rate, reflexes needs to be done. And should there be any concerns or not being sure of, it's important to give a Maxulf straight away, 5 grams intramuscular on both buttocks or 4 grams stat IV, just to make sure that the preeclampsia bit is taken care of.
How should a primary level healthcare worker counsel the pregnant woman or her family in such cases?
In the non-emergency conditions, if the ANM happens to see a patient who has been on anti-epileptic medication, few points needs to be highlighted. Number one, has the folic acid been given, and as early as possible, ideally preconceptionally 5 milligrams of folic acid needs to be given. Both the lady and the family members need to be counseled that triggering factors have to be avoided, like stress, dehydration, work, too much of work, or anything that gets the seizures in the patient. The patient has to realize that the medication is safe for the pregnancy, and it is better that she takes this because the seizures would be more harmful. So the medication has to be taken appropriately at the desired time. And a neurological opinion needs to be taken because this may need to be changed. The dosage would need to be changed as the pregnancy unfolds. This is for the non-emergency condition when the ANM goes and visits the lady who has epilepsy. Should there be a emergency condition where the patient has had a fit in front of the ANM or in the primary health center, the relatives need to be advised that such condition can happen again, and so a referral at the earliest possible to the tertiary care center needs to be done, and that thorough examination along with the management in the tertiary care is desirable.
Dr. Poonam, can you please highlight the management of a pregnant woman with epilepsy at a tertiary care center?
So in the tertiary care center, the specialist takes a detailed history in order to understand what is the cause of the fits the patient is having. If it is a fit which has been classified as an epileptic and has had investigation in the past, then the dosage of the medication needs to be changed with the help of the neurologist. The other causes need to be looked into, and this includes causes like metabolic problems, infections like malaria, encephalopathy. These can also cause fits, as also some history of trauma with respect to the brain, like thrombosis or tumor or any hemorrhage in the brain. And obviously in pregnant women we have to look into the blood pressure and make sure it's not preeclampsia. So having taken a detailed history, the next part will be the examination, which includes the routine antenatal examination and then a specialist neurological examination, including the reflexes checks, both the deep tendon reflexes and the peripheral reflexes. The fundoscopy is also of great importance here, and then take blood test for investigations, which could be the antenatal investigations as well as certain investigation to rule out the different causes of these issues. The specialized kind of investigation would be the EEGs, ultrasounds or an MRI of the brain should there be a need for it. But it has to be done in consultation with the neurologist, and then the dosage needs to be changed accordingly. And for the baby, there are certain scans that need to be done apart from the 12-week scans, which is the Anomaly scan to look into the various organs of the baby just to check there is no congenital malformation.
So it is very important for our primary healthcare workers to remember that management of a pregnant woman with epilepsy at a tertiary care hospital involves a multidisciplinary team approach involving a specialist OBGYN, involving a specialist neurologist, a specialist pediatrician and a specialist radiologist. So Dr. Poonam, now let's talk about the intrapartum care. We know that labor involves pain and dehydration. So how do we manage epileptic women in pregnancy during labor?
Epileptic women are more of a risk of having a seizure during the labor, and therefore triggers like the stress, the pain, dehydration needs to be avoided by hydration. Epilepsy is not a condition for cesarean section, and these women can have a normal delivery while having a good surveillance of both the mother and the baby.
So for optimal intrapartum management, we just need to remember few basic points, that is avoiding insomnia, excessive stress, dehydration and providing adequate labor analgesia to these women. Also, to ensure that these women continue their anti-epileptic medications even during labor. If she is not able to take her oral medications because of vomiting, etc., these medications can also be given parenterally. To keep emergency medications like diazepam, clobazepam handy in such women, and to ensure that a team of senior obstetrician, anesthesiologist, pediatrician and neurologist are available at the time of patient's delivery. Epilepsy in pregnancy is not an indication for a cesarean section as emphasized by Dr. Poonam. Dr. Poonam, now one last question. What special care needs to be taken in the postpartum period in women with epilepsy?
we need to remember that postpartum period is a condition where these women are of more of a high risk for getting seizures again. So a medication which has been prescribed earlier has to be continued, although the dosage would need to change in the next 10 days' time. These women are at increased risk of postnatal depression as well, for which a watch out has to be done and adequate counseling needs to be done. Triggering factors like stress, dehydration, pain needs to be avoided, and medication or support system has to be given. The breastfeeding can continue. Babies would need about a milligram of vitamin K to reduce any bleeding disorders. These women have to be monitored by the neurologist after discharge once the patient goes, and has to be followed up by the ANM at the PHC or at home. The contraception needs to be highlighted, because long-acting contraception in the form of copper coil or Mirena, which is the coil with the progesterone hormone, or even the medroxyprogesterone long-acting injections can be given, so that these patients don't get pregnant in the near future, and we can time the next pregnancy accordingly.
Thank you so much, Dr. Poonam, for simplifying this extremely complicated topic for us.
Thank you, Dr. Karishma.
So in today's session, we learned about epilepsy in pregnancy. It is very important for our primary level healthcare workers to remember that they play a very important role in management of these women. They need to take a thorough history involving the patient's duration, severity, type and frequency of seizures. They need to ensure that the patient is on folic acid supplementation. They have to make sure that she is on anti-epileptic medications and continuing the same during her pregnancy. Also, if she is not on anti-epileptic medications, the medical officer can start her on basic anti-epileptic drugs till she is referred. But most of all, they need to refer these women timely to a higher center. At higher center, they will be taken care of by a group of specialists involving a specialist obstetrician, a specialist neurologist, a specialist pediatrician, anesthesiologist and radiologist. Also, intrapartum care is of utmost importance. Avoidance of dehydration, insomnia, excessive pain, continuation of anti-epileptic drugs during labor is the key to optimal management. In the postpartum period, the primary level healthcare workers have to ensure that the woman is well supported, that is, she is getting adequate rest, she is pain-free and she is continuing her anti-epileptic medications. They have to ensure that the patient receives proper breastfeeding counseling and she receives proper contraceptive advice. To know more about epilepsy in pregnancy, please refer to our protocols. Thank you.
This brings us to the end of this training session about the identification, management and treatment of epilepsy in pregnancy. Remember to refer to the high-risk pregnancy management protocol for more details.